So, thank you very much. With that, I am going to introduce our panel. So, so now we're going to go straight into the panel. And Tony Coles, Tony, can you come on up? So Tony is the CEO of Onyx, and Tony's been absolutely fabulous in the community because he stepped up and said, okay, this isn't about industry and academia. This is about how can we build within the Bay Area a strong infrastructure, strong community for supporting these health improvements that we want to see. And then Gary Firestein, everybody's getting mic'd up, I guess. So yeah, come on up, Tony, have a seat. Look at, they're sort of all lined up there. Anywhere, yeah. You get the first choice. Ah, good. Okay, Sharon Terry's the next one. So Sharon, as I mentioned already, Sharon was on the IOM panel. She's co-chair of it. But Sharon's the head of the Genetic Alliance. And the Genetic Alliance has been really an amazing institution. It's cut across all the disease advocacy organizations to say, okay, what are common problems that we all have and how can we address those together? So really happy to have her. We're working on a project too with them related to recruitment. Gary Firestein, I introduced him too when he was sitting out there. So Gary is my counterpart at UCSD. Again, Gary's taken over. He's now the head of the UC Braid and has been terrific there, pushing the group beyond its comfort zone, which is critical for it being successful. And then Keith Yamamoto, everybody knows, I think. Keith's our Vice Chancellor for Research and Vice Dean for Research. Keith's been a great partner to CTSI in a lot of different ways. And now is leading up the campus's precision medicine efforts, and is going to talk a little bit about that. And then finally, if we can get a mic on him. Good. Is Reg Kelly. So Reg Kelly heads up the QB3. And again, QB3 has also been a great partner to CTSI, but QB3 has been doing this for much longer than we have, and has developed some really interesting mechanisms, which you may already know about, but he'll tell you more, to think about breaking down the barriers between academia and the outside world. So thank you all for doing this. I'm gonna sit down. This is like a little like Oprah Winfrey, or I don't know who does these big panels. So thank you all for doing this. What we're going to do is we thought we'd start off and give you each, we don't have too much time, but 3 minutes or so to make some comments. And what we asked them to do is tell us what we should be doing. How can we do this better? What do we need to do to achieve this sort of national mission of improving health? So where should we start? Keith, you want to start?
Sure. So I love the challenge that has been laid out for us, which asks the question, what can the CTSI and the National CTSA Consortium do to radically transform biomedical research? I love that word. It really pushes us. So here we go. So what's the transformation that I could imagine and hope for? I would say that sometime in the future, most biomedical research will be carried out in small teams, 3 to 6 PIs, and a selection of their trainees, not all of them, not whole labs. Each faculty member would be part of, let's say, a half a dozen such teams. The teams would be self-assembled, that is, the groups would come together because they find a common interest. They would be dynamic. You finish your task as a molecular biologist on this team, and it's time for an epidemiologist, so you're off the team, or an idea just doesn't work. They're transdisciplinary and working to solve specific biological, biomedical, clinical problems that they choose to work on. The teams would include academic PIs from multiple institutions. They would include, as I said, a selection of trainees from those labs, and they would include company scientists, industry scientists. And the support would be from the federal government, from industry and the industry consortium, plus of course special specific projects, and from nonprofits, patient advocacy groups, for example. Again, a consortium and nonprofits. So that's the fantasy. That's the radical view. Where does the CTSI play it? I would say three things. The CTSI, CTSA consortium would really help to galvanize the concept of a research continuum that really crosses two orthogonal planes. One is the science plane, basic curiosity-driven research to translation, to clinical research, to population studies, and then out into the community of patients and well people who would like to keep it that way. And the other orthogonal sector are the stakeholder groups, academia, industry, private sector nonprofits, and government, regulatory and funding agencies. CTSAs could help to encourage and enable building information commons and knowledge networks. This would be the enabling tool that would allow investigators to discover each other and the relationships of their work that they didn't realize before. And finally, they would promote and enable these self-assembled, dynamic, transdisciplinary teams to form and prosper through grants and other methods of support.
Great. Good. Thank you. So, Gary?
So thank you. So first of all, I want to thank you for inviting me up. Please, next time, no fog in SFO.
We didn't think Gary was going to actually make it because it sounded like the flight was canceled.
I was on the flight and they said they closed the door, and if you looked actually on your iPhone, it said that the flight had left. You know how they do that. Yeah. And then they said, air traffic control says we're leaving in 3.5 hours. So and they got us all. Anyway, I made it. So, but I'm very impressed by the showing here today. I mean, I could give free beer and pizza. I could have wine and cheese. I don't think I could get this many people in San Diego. So this is very impressive, and I think the CTSI has done an amazing job of tying people together. And I'm actually learning a lot from you guys in terms of how you generate that esprit de corps. So we were only given, you said 30 or 3? I don't 3 minutes. So the main point that I wanted to make was one that you made, actually, which is de-siloization. And I think that is the greatest impediment that we have to transforming our research and being successful. And we see it in a microcosm amongst laboratories, slightly larger in terms of departments and ORUs on our campuses, and then even across the state with our various UCs. And then we don't even begin to mention what goes on across for the 60 CTSAs across the country. So as Clay knows, I'm a big believer in starting small and being successful, and then being able to export those ideas outward. So I actually think efforts to rush into 60 university consortia are often implode under their own weight. This is one of the reasons why Braid was able to be successful. We have a considerable, we have shared values, we are all equal partners, and we have accomplished a lot in the last few years, but there's a long way to go. So if you wanted my suggestion in terms of how to move ahead from here, it's to break down some of these silos that still persist. And I think IRBs and contracting and everybody having to have a high throughput screening, or a whole host of these things that we're kind of building separately, although we can clearly leverage from each other. So that would be my suggestion.
Great.
Thanks very much for inviting me here today. I was the co-chair of the IOM panel, and so I thought I'd bring you a few thoughts from that, but also some thoughts I think that spin out from 9 months of studying the CTSA program. As Deborah showed, we came up with a series of recommendations, and there was a thread through all of those, and that was that the CTSA programs start to be much more outward-facing, that it's done a reasonably good job of being focus or home for certain things, but that we really look to what does a national network look like and how do we change the nation's health. That includes things like partnerships and boundarylessness, like we've been talking about, and UCSF CTSI has some really good examples of that, so I think you're very strong there. We also talked a lot about a not invented here mentality that is part of science and academia, and that we need to remove that. And I think that's easier said than done, but there are some really measurable ways we can move together away from that. And I come from a citizen science world, not at all an academic one or an institutional one, but see lots of opportunity for us to start to move in that direction. That brings me to a couple of things that maybe looked like NCATS is not paying attention to, but I think they're paying attention to elements of that, and that is the community engagement and the training pieces. For community engagement, we really said we don't mean the standalone programs that might advise something, but I say this often as a community person. I have 2 kids with a genetic disease is why I'm in this at all. I often say, don't invite me to the table. I'm not happy to just sit at the table. I want to plan the menu, plan the venue, plan the meal, and plan who else is going to come with you. And so that's the kind of thing that we're looking for the community. And that means from T0 to T4, all the way through. So being part of those teams that Keith talked about, part of them, part and parcel, figuring out the research questions, how are we going to ask the questions, how are we going to roll this out, all the way to the end with how we're going to take the drug or the intervention. I think you all should export your successes. I think UCSF has a lot of successes, having looked at a lot of the CTSAs and the nation's academic programs. It's time to move those out. And the last thing I'll say is that it's easy to feel threatened in a time of scarcity. You know, when you look at a number like 25% of your budget might go away. But I think, and Minnie and I were talking about this, I think it actually provides an opportunity because it says to us, we can't continue to behave in the old way. We all know that the old way wasn't really working. And so there's a kind of energy in this time of looking at how we're going to move together. I think about this like a garden. We have to think about what do we keep and what do we not keep, what's going to make us healthier and stronger, what's going to make the plants in that garden stronger. And I think the biggest thing is to do the thought experiment of what does we mean, and that the moment we get to fear, whether it's fear that my program will be cut, my idea is not going to be taken to be the best one, that for me is a fabulously generative place because it's a place where I start to say, whatever I'm afraid of is exactly the thing I need to go forward with. So together, building the we that will be the CTSI in the future will actually advance the health of the nation.
Thanks, Tony.
Well, first of all, Clay, thank you. Can you hear me in the back? Yeah, thanks for the invitation and for the chance. I obviously represent the biopharmaceutical industry, but I loved your slide about tribes because I show up wearing so many other tribal headdresses, as it were. I'm not only a patient and the father of a cancer survivor, but I'm a physician and a former clinical researcher. So I bring each of those perspectives to this conversation and to what we do all the time. I always love starting at the end. And the end of all of this conversation is the patient. Because ultimately, everything that we're doing is literally on behalf of the patient. The next advance, the next discovery, the next translation into either a device or a therapeutic intervention. And if you think a little bit about ending with the patient, there's an innovation chain that exists. It starts oftentimes with the idea, which requires funding, or vice versa. Funding brings an idea. But then it moves quickly through the academy and into the hands of a biopharmaceutical company that, in collaboration with regulatory authorities across the world, then works very diligently to get this innovation into the hands of a patient. Well, we each have a role to play, and what's interesting and vexing in some ways is that we actually just aren't set up to collaborate the way the innovation chain itself is built. Your comment about silos is so true even for industry, but these problems are so complex. The next advances in biomarkers, the next advances in genomics and its application to devices, how is it except through collaboration that we will crack the code on these things for the benefit of patients? So the idea doesn't stop here in the academy. It doesn't stop certainly at the biopharmaceutical company as we develop and do all the appropriate regulatory things. It ultimately rests with the patient. And I'll argue that there are three things critical in that: partnership, transparency, and prioritization. And I'll stop there.
Great. Thanks, Tony. And Reg?
Oh, thank you. Well, like Keith, I was thrilled to be on a panel that's discussing radical transformation. I've not been involved with something like this since I was an undergraduate, you know. And so I'm looking back on our days as undergraduates, remember how it was, right? There was establishment figures, we're always against them, and they were always blind to the major problems. So now we're the establishment, right? So what problems, I ask myself, might we be a little bit blind to and we might want to look at? So I've got 5 I wanted to mention. Some of them are reiterating some of the things we've already heard. One of them is conflict of interest. Like I am, of course, just a usual scientist here, but come at it from a slightly different point of view now because, like Tony, I have a spouse who is very seriously sick. So I've been going to patient advocacy groups, I've been going to faster cures, and I've been looking at our community from the outside. And actually what you see isn't very pleasant, right? What you see is we all believe ourselves, we're disinterested chasers after truth and cures for maladies. To put an extreme case, when you look from the outside, what you're getting is people saying, oh, these are entitled aristocracy that are using the NIH to further their careers and the careers of their friends. Now, of course, we know that's not true, but you know, I think what we have to do is to look at the conflicts, not between ourselves and industry, but our internal conflicts, right? What are the conflicts that are going on? I think the CTSA could play a major role in doing that. The silos thing, absolutely. I would like to make, let me go one thing. Academic structures, right? We could really change the way, we'd have this medieval way of doing academia, right? So we have, in our basics, in our clinical sciences, we have neurology looking after a tissue, radiology looking after a technology. So when you get neuroradiology, all hell breaks loose, right? Who does that belong to? Now, you can't do much to change that in the clinical departments. I've heard those arguments, but we could really change it in the basic sciences. I mean, nowadays, to have biochemistry, pharmacology, anatomy, physiology makes no sense at all. We could really, as Keith was saying, restructure the whole system around something that makes sense. Generalists, silos, yes, we're all rewarded for becoming increasingly specialist. What we tried to do in QB3 and what I do now is to try and be a generalist, right? So what I think is a position for a different class of academics within our university whose job is to go around and be integrators. Toyota does that, you know, has its paint team, its tires teams, its engine team, but has integrators that go around and say, do all these things work together to produce a good car? Why don't we have people like that within the university to produce a good thing for patients? We started doing this. I think that's a good job for ancient faculty members like myself, by the way. Teaching, I don't think works very well. I mean, we think nowadays if I want to learn something, I just go up, look at Wikipedia, right, Google. So why are we teaching the same way as we used to teach? We should, so one thing you can't get when you go to Google and Wikipedia is what is not known, right? You can't organize the lack of knowledge. So one of the things we started trying to do with CTSI was do this anti-medical school to teach our students what is needed and to look for that. The final thing then, since I come from QB3, I have to say, I would love it if CTSI would see themselves as translating not just from the basic science to the clinic and back, but to try and go and translating all the way out into the private sector. We in QB3 for the last 9 years have really worked up some really good ways of encouraging young people to start their own companies. We've got our own mentorship programs, we've got our incubators, we've got funding mechanisms. We should look at a continuum and think that the people who leave our university and go do startup companies are just as prestigious, just as much to be respected as people go and becoming assistant professors. Currently, I feel in QB3 we're a little bit of an appendage. I would love, although Clay and June and I have been working on this for some time, I would really love to see QB3 become an integral part of CTSI so that we flow all the way out into the private sector.
Great. Good. Wow, those were fabulous comments. Thank you all. Those are great. Boy, it's like I think we just wrote the introduction to the renewal.
You're recording this, right?
Yeah. But we,
I'm
you know
sorry,
what?
it'll look a lot like ours.
That's good. That's actually right,
Isn't that
right?
a good thing? Yeah. But we didn't come up with the solutions that'll go into the next part of the grant. it's interesting that we all identified that the siloization was a critical problem. Now, slightly different perspectives about where the opportunities were there, but clearly an opportunity from, whether it's in the community, across institutions, from basic all the way out, but also involving industry, bringing the knowledge together too from siloed groups, working with industry, and then even institutionally thinking about too how we create companies out. And then I loved your comment too, Reg, about the basic science departments. It's so interesting that that would be such a brutal battle. Why? It's just, all of a sudden it struck me that, as we were dealing with more and more of these examples of why is that such a brutal battle, even on the clinical side, I gotta say, for neurology to work with neurosurgery and be one and have a neuroscience, line of care would make care more efficient and better, and yet it doesn't happen. It is really in our genes that we have trouble doing this. So my question to you all is, so we've all identified this as a priority, so now let's get to the meat of how we're gonna solve this. Keith, you mentioned that creating a knowledge network could be useful. And just to put it out there, where's Leslie? There, Leslie Yuan's responsible for UCSF Profiles. So Profiles is a beautiful thing. I don't know if you guys are ever on it. And it's become the most hit site at UCSF. And it's, anyway, and for most individuals, it'll be on your page 1 of Google if you search your name. So it's a great thing, it does a lot. But I don't know that it ever connects people. I mean, I know it does because I use it to connect people, but can I say that was our crucial reason for starting it, was to bring together people that couldn't otherwise find each other. Can we actually demonstrate that it's done that and that's made a difference? So I'm taking that off the table as a potential solution for you all. That's something we have to solve, and I'm asking you, how can we solve this? So Keith, you brought up funding too. I'm going to take that one off as well. We can have funding that forces people to work in teams across silos. But so what else can we do?
Why not? Why not? So I don't know why you're taking either of those off the table. But
Well, I'm taking them off because I know they're problems and I know we got to deal with them. I want to see if you guys have any other ideas about how we might move things forward.
Let me see if this helps, Clay. So this conversation is a great opportunity. I don't know how often we've done this. Presumably we've done this each time we've prepared the application. But how many times have you had an industry person or persons come and join you? And so what's interesting is that having left the academy 20 years ago to come to industry, there was such intense suspicion. I think this microphone is not working.
Yes.
Is it working?
Yeah, sorry.
Okay. I'm getting is that any better? I'm getting thumbs up in the back.
Yeah, now they hear you.
When I left industry 20 years ago, there was such a distinct mistrust. Left the academia, there was such a distinct mistrust of industry that I think that's created some enormous barriers. So why can't we just start with the dialogue? Why can't we have the conversation? So, for example, in about 3 weeks' time, I'm bringing the entire executive team for Onyx to UCSF for a site visit. Because I want them to see clinical research up close, I want them to see patient care up close, and I want them to have a deep appreciation for where the innovation comes from, in many instances, that we have the stewardship and responsibility for. So how is it that we can think about the collaborative conversation and fostering that and not being afraid of it? For instance, we operate with the capitalist model in this country. Until we move to a Marxist or a socialist model, it's what we've got. So let's respect that, respect the various interests and points of view, and then figure out how we optimize, not how we run the opposite direction.
Mm-hmm.
So Clay, let me just expand on what Tori's talking about and challenge you a little bit. So I think that there's no ways that any rules or regulations are going to change the site. I think you need two things to make it work. You need an enabling tool that allows people to make the silos at least porous, if not disappear.
Mm-hmm.
And then you need an incentive for them to use the tool. Right? And those are the two elements that you're taking off the table.
No, I'm not.
Hold on. So if we had a kind of knowledge network, kind of profiles pardon the reference to my word, profiles on steroids, that would allow people to find each other and find links to their work that they didn't know about before. And then built a support system that said, if you self-assemble a team of investigators that will, across academia, across academic institutions, across industry, trainees and PIs and so forth, you assemble a team of investigators to take on a problem in a new way that you're really excited about and have imagination for. There's support for it. Right? The current system doesn't support that, and we don't have an enabling tool. But if we had enabling and incentive, then I think that we could break the barriers down. There's no set of rules that's going to do it. That won't work.
Well, I think, I mean, what you're talking about, in essence, is the sort of tribal, again, the tribal nature of our institutions, where we're divided up into departments and divisions and ORUs. And we've had a discussion about, should the old department structure remain? It was something that was evolved out of the Flexner report years ago. Almost all of the research that is really going to be impactful at this point is going to be multidisciplinary. Should the departments in academic institutions be de-emphasized and instead have, well, you referred them as self-assembly, and it can either be individuals or on a center or ORU where they kind of come together and then come apart when they cease to be useful. That actually attracts tremendous antipathy when you talk about breaking down some of these tribal barriers. But the one thing that is sort of the elephant in the room, and it's not just having incentives, it's eliminating disincentives. And one of the key disincentives is how we evaluate people for their success and promotion. And currently, it's like the Pogo cartoon. We have met the enemy and he is us. We review all of, in CAP or whatever the committee is called up here, we review the files. If you don't, you start counting papers, how many are senior author, how many grants do you have, and you strongly disincentivize people. So one of the things that we've finally been able to get, and you can't run a core, you get dinged for running a core. So one of the types of things that might be interesting to improve this is, number one, is get formal recognition for team activities. And we're just starting to move in that direction. And the other is actually to get credit for helping people. So the whole area of cores, I'm not sure if you've had the issue here where if you are on a core, your reviewers say this is great, but it's not your own work. I'm sorry, you're just providing a service. But service is actually part of our academic mission. There's service and teaching and so on. So you actually need to be able to get some sort of academic credit for just helping people as part of meeting the mission. So reassessing what the criteria are for success in a career, I think, are going to be absolutely essential to moving forward.
Good. So one is getting back to this point, how can you get these academic generalists because you're not rewarded? I think this is I'm not kidding, I think this is a real thing for people like myself who are retired, and I've closed down my lab. Right, but since I've been around a long time, I know almost everyone all through this campus. So I can connect people together. And so my creative life now is, in fact, connecting people together. And I think it's a very valid thing. I don't get paid for that at the moment, but that's fine, I'm retired. But I think that's something that we should be creating, a faculty position who get rewarded for being a generalist. And the metric would be how many sort of consortia did you put together, how much granting did you happen to bring into this. So it wouldn't be anything to do with papers. We in academia, if we just were to introduce that faculty track, we could make a big change in this. So what I've been doing as an example for the last 3 months is working on a consortium on 3 campuses on longevity, how one can do molecular interventions that might prolong life, slow down aging. And so we have now 32 faculty. We've had a workshop. We're going to have a symposium October 16th. And it's great. There's people working together, like protein structure people from anesthesiology, working from vascular surgery, all sorts of group of people that have never worked together before, can now working together because I have the time to put this together. I'm not trying to say I'm the right thing. It's just a model of how it can be done until the university decides to fund that type of slot.
I think you're precisely right. There has to be someone who can be the champion of these self-aggregating units. And although the U54, there's not a notice of award yet.
Yeah.
Make sure you understand that. But that's an example of how it can be done without,
The U54, that's the braid, that's the thing that I mentioned that's braid to help to fund development of new therapies in HLBI space, heart, lung, and blood.
so we started out with 3 separate proposals. It was UCSD and Irvine, I think it was UCSF and Berkeley, I think, and UCLA and, God forbid, USC.
See, he's doing it.
This is strictly sports, though. In the end, we were able to coalesce and collect all 5 UCs, all 5 schools of medicine, all 5 engineering schools, and business schools in a way, and everybody put in matching funds, actually. And this is the reason, in the end, that it appears that it's going to be funded. So it is actually possible to do. And I think these are the sorts of things, this is just the first one that we were able to accomplish. But it shows what we can do if we sort of let our guard down and detribalize, I actually like the sense of that.
Wow.
I still have trouble with SC football.
Questions from the audience, let us know, and we've got mics that'll go out. And then I've got one. So Sharon, so the challenge of, so we do have a great community engagement group. I mean, it's a fabulous group. I showed you the SF HIP, but they're doing other great things too. But we do not seek input from community in, like how we structure some of our earlier translational programs. Or we do in recruitment, we know we need to, but we don't in sort of other ways. So, and that is an interesting silo, or 2 silos that exist. So, I mean, how do we even, not everyone's as knowledgeable as you are about all these steps and everything. So how does one set that up? Or how could we do that? And what would be the logical consequences of doing something like that?
Sure. So I think we have to think about community broadly. I don't think that communities, as we think of them traditionally, should have a lock on this community engagement. So in the report, for example, we said we mean nurses and social workers and all kinds of people from the community around the CTSA. We also said in the report that there already are some very good best practices that have been promulgated by CTSAs that should be incorporated, and so those are easy, low-hanging fruit. The next thing I think is to say, what does it mean to engage truly in a participatory way everyone, and this does break down silos at the same time. And by that I mean not just saying, okay, it's fine for you to bring forward a basic science proposal by yourself in your lab with just your group, but instead to say one of the things that will be rewarded, this idea of incentivizing, is broader engagement. And again, whether that means that you're going to engage some social workers or some OT, PT people, and what's the question as I move forward. Now, you're right that not everybody's prepared to do this, even professionals, and certainly not general community members or underserved communities, and so training is going to be important. And we said in the report, training, and this is why I don't think it will be ignored, really means looking at what are the new models of teamwork, what are the ways that we need to use online interactive gaming, non-traditional ways of teaching in a very broad way, both for the community members and also for the members of this community. Because one of the things we recognize is it's hard for this community to understand what does it mean in my basic science or my T1 project to actually engage somebody else. I think it's a thing that is not going to be done in one community. I think we're going to have to work as a nation and export best practices from around the nation to do that. We're definitely committed as Genetic Alliance to help like the Community Campus Partnership and others make sure that the CTSAs have the tools they need to do that. And then the other thing we think is important, it's got to be measurable. Because if you don't have metrics even for that, then it doesn't get rewarded, it doesn't get valued, and we need to figure out what are those metrics and how do we value that.
Good. Yes, John.
My name is John Featherstone, the Dean of Dentistry here at UCSF. I'd like to pick up on a comment that Gary made, which has driven me nuts for years, and it's come back to haunt me twice in the last couple of months. And this is the mentality of people on CAP and the mentality of reviewers at NIH who say that people who are independent investigators must have their own laboratory. And I'll quote you a couple of examples of that. We've got a young man with a K award now, assistant professor, where NIH reviewers have insisted that he has a separate lab. So we've moved him out of the umbrella of his mentor, put him in a separate lab. I think that's terrible. I think it's retrograde, and it's against, in my opinion, him developing into a non-siloized investigator. And we've had another example, and I can go back in my own life, and people have worked with me, and I don't know how we change other than mandating that CAP and NIH reviewers disregard this nonsense. We've got HSE 15, for example, now, which has 5 PIs on it. They're all getting on together just great. They're interacting. This is what we want. This is getting rid of the silos. We're going to be setting up 3 new floors in the HS towers when CSB is under reconstruction. We're going to be putting 8 investigators in 10,000 square feet. How do we address their promotion and merits with CAP, and how do we address NIH? Don't nod, Keith. Tell us how do we do it.
Keith, I was gonna send that one to Keith. So Keith's done a lot at the national level thinking about NIH policies. You know, the multiple PI change in NIH is a fabulous change. It's not PI, co-PI, it is multiple principal investigators. Is there a way, I mean, what else is coming, and is there a way we can influence that?
Well, I think there is. I mean, Gary said earlier that we need to be able to do experiments at a scale where they'll work. And I think the CTSI here, the CTSA consortium to some limited extent, that you can pull that whole group together, can actually get a stake in the ground on some of these things. As John knows, we're working locally to try to affect the way that our promotions committees operate and the values that they hold at the highest point. And I think simply the visibility and the potential influence of these groups at the national level can begin to actually have an impact. These are the battles that I think are really worth fighting about silos. I think that in contrast, both Reg and Gary pointed out the real complexities of trying to take on departmental structures. It's a good idea to break down the department structures as we have them, but it would cause such a battle that it would just be a distraction. It's very difficult to try to imagine how to make that work. So I think that the way to go after silos of that sort is to make them porous, poke holes in it, build something that rides over the top of those structures and makes people not worry about what their department stationary says, but instead be able to join forces with other individuals and groups that are interested in the problems that they're interested in. Instead, battles like this one that John has brought up, of being able to really go after the kinds of policies that serve as disincentives is really where the fight should be taken. CTSIs can play a big role in that.
Yeah, one of the ideas proposed, actually, that will be discussed. I think, Mike, are you leading that, Mike McCune? No? Oh, Bill is.
Yeah.
So anyway, that's a yeah. Renee, I think you're next, and then.
Hi. Renee Navarro. I'm the Vice Chancellor of Diversity and Outreach and the Interim Vice Provost of Academic Affairs. I just wanted to comment on the remark you made relative to our Committee on Academic Promotion. Our CAP committee, we've worked over the last probably 5 to 6 years to actually implement a policy at UCSF whereby we actually give contributions for, independent contributions to collaborative work is recognized by our CAP committee. And our faculty have not faced unsurmountable hurdles within our promotions process once it gets to the Committee on Academic Promotions, once it gets to the Dean's office level. I think there are still some challenges within the departments as we define for our departments what does it mean to be ready for tenure or ready for promotion at the departmental level. But CAP is on board, and we talk about this on a almost annual basis in the CAP retreat. So that has not been a barrier here.
Can you hear me?
Yeah.
I'm in psychiatry. I've been teaching behavioral medicine to medical students here for about 25 years. Over the course of my teaching, the prevailing model went from a biomedical model to a biopsychosocial model. I would suggest that the ultimate silo is Descartes' error. That we talk about the biopsychosocial model, it is simply not implemented in research. Biomedical research and research on mental disorders and clinical health psychology are extremely fragmented. I mean, how many clinicians or researchers in this room have wondered, why can't I just get a simple screen to measure the pressure? Well, these tests now exist, but people don't know about them. They don't have access to them. So I would ask the panelists, how can we use the CTSI to create an infrastructure for biopsychosocial assessment in which we create transdisciplinary teams that really study psychosocial functioning, psychosocial behavior, mental disorders integrated with biomedical. Specifically to you, Reg, you're interested in studying longevity. Do you have neuropsychologists on your team?
No,
Do you have clinical health psychologists on your team?
no.
Do you have clinical psychologists on your team?
No, let me just be clear before we do this litany here. We are out to try and get molecular interventions that will actually perturb the rate of aging. So for most of those things, since we're very molecular, we're not doing socioeconomics, we're not doing anything social. That's not our mandate. It's to stay within the molecular biology of trying to get intervention. So it would be very unusual to bring in a health psychologist.
Sure, but if you want to translate that to people are psychosocial organisms. And so an individual's cognitive status has a lot to do with aging. This is very typical. We don't have to debate your specific project, but biomedical researchers always kind of add on mental health and behavioral medicine as an afterthought, not integral. People who need to be at the table in these planning grants are behavioral and social science researchers, psychiatrists, neuropsychologists.
I think it's a great point. Yeah, I think it's a really interesting point because I think it's beyond just in the disease focus, but also just in terms of the way we think about how we reach out to communities to participate in research, and also how the psychosocial state of patients impacts the results in any clinical trial. Those are all issues that actually are underappreciated, under-discussed.
But I mean, I think just to broaden it so that it's, again, disease agnostic, because the CTSAs are generally not out to pick winners or losers in terms of a disease focus. The issue, this actually gets in part to the issue of information systems and how one integrates information from many different sources into a scientific project or clinical research. And there are innumerable barriers that are imposed. And if you have ever tried to put, for instance, a questionnaire into EPIC, you will understand that that is essentially, the holy grail. Before I go, I want to get something changed in EPIC. but that's exactly right. So we, in rheumatology, we try to put in a joint count thing, and I've been working on it only for about 3 years or so. So we need to be able to integrate that so that we can have the healthcare that we're providing be available then as a tool for research, because it has all of these domains included in there. And then in terms of longevity, please hurry. my one request.
So I think your point is really well taken, but the solution can't be that we build a little psychosocial silo. It really needs to be this integrative approach to allow people to discover that there is important work that relates to what they're doing as molecular biologists or whatever. And that's the enabling tool that we'll be talking about in precision medicine, of building this knowledge network. And that's how we're going to find each other. So I think that your point is really well taken. There may be many people in this room who feel that if only people would just know what it is that they're doing and have been working on for a long time, laboring successfully but in isolation, that things could really move forward more readily. And I'm sure that that's true. We just need to be able to do that.
There are forces that are pushing back against that, though. So, for example, in the Wall Street Journal this morning, there was an article about physicians that are not accepting Medicare, in part because they didn't want the information from the patients they were seeing going into the medical record. And there was a specific example of an OBGYN who didn't want libido questions to appear in the general medical chart, for example, for one of their patients. And so they're deliberately putting this schism in that puts up barriers. And that's not good for the patients, and it's also not good for research enterprises that are trying to start teasing apart how, again, psychosocial or other difficult to measure effects might have an impact on health.
That's where we need Sharon and her groups.
Yeah.
The patients.
Yeah, thanks, Clay. I'm Bob Hyatt. I'm in epidemiology and biostatistics and also the Cancer Center. The people that study this area of team science have been at it for 10 or 20 years now and actually looked at a lot of the sort of process issues that we're talking about. So it's not a new thing. And I struggle with what's needed to move things along. And I think it's actually examples. To take Tony Cole's point, I think we need to start at the end. What does it look like to have a successful collaboration, transdisciplinary approach that has brought together psychiatry and economics and genetics into one project? How many examples can we come up with? Not very many. I think CTSI could help us by thinking about that hard and coming up with some examples that show us how to do it. I think that this place especially is very collaborative. I think people are open to teamwork. I don't think the silos are all that bad. I just don't think people know how to do it. And I think if they had examples where there was some successful collaboration and some successful new ideas coming from the interstices between disciplines, it would be a lot easier. I think there's some ideas out there now that might go that direction. We're worrying about it in the Cancer Center. I think it's a job that CTSI could take on that would be of great benefit to us.
I think that's terrific, and I think we've seen in other industries where it has worked to collaborate to create something new and break down boundaries, sometimes kicking and screaming, but still. I think we've also seen that in industry on occasion. And I think the other thing, and we said this in the IOM report, there has to be a chance to fail because you're only going to be as successful as you risk. And we say the people who live with disease, and again, agnostic of what disease, risk every single day a lot. And we have to up our ante and risk and fail at some of these models and build the models that then could be propagated.
Well, let me build on that if I might. One of the interesting things that's happened recently in industry is the concept of the pre-competitive space. So you find no more fierce competition than around companies, competing in the same disease category, the same therapeutic area, and it is hand-to-hand combat is what it looks like. Mm-hmm. But somehow, some of these disinterested parties, if you will, they're really compassionate and very focused on their topic. Take a patient engagement group like the Multiple Myeloma Research Foundation or the Cystic Fibrosis Foundation or the Myeloma Repair Foundation, pick any of them. They've been extraordinarily successful at the venture philanthropy approach, where they have raised research dollars and then turned those dollars back into research grants for those disease areas of interest. Well, interestingly enough, they've been extraordinarily successful at getting companies now to collaborate in this pre-competitive space where there's a bubble. So to the point here, why not host a conversation similar to this where you have Kathy Giusti from the Multiple Myeloma Foundation, Bob Bell from the CF Foundation, and bring them into this dialogue as well as one or two other industry people and find where that interesting common ground is. It's been extraordinarily successful. They've raised $250 million at the MMRF over a 15-year period of time and have channeled almost all of that directly into research that, in our case, led to the successful development for cartolus. So there are all sorts of interesting models if you open the aperture to the discussion.
Yeah. That's a great example. Chuck?
Yeah, I'm Chuck McCulloch, head of biostatistics in Epi and Biostat. And a couple of months ago, I served as a reviewer for Patient-Centered Outcomes Research Institute. And they made an amazingly small change to the NIH grant review process that made a huge change in the grant review. And that was 4 reviewers, 2 scientists, 1 stakeholder, 1 patient. That changed the entire dynamic, capitalized on overachievement, because these were put out clearly as what you had to do to get a PCORI grant. I was flabbergasted at how well the dialogue worked between the scientists and the patient and stakeholder groups, and they came together, they understood it had to be good science, had to be responsive to patient and stakeholder groups. Small change made a big difference.
Yeah. Very interesting. Yeah, Dan.
Dan Lowenstein from CTSI. So I really like the insight and the direction that the conversation is going, and I'm struck by the sense that we're really, no surprise, we're questioning the very structure that we exist in order to advance science. And I want to emphasize also the history, as you pointed out. It's pre-Flexner. It was actually the folks in the late 1800s who took a look at what was going on in American medicine and turned to Europe and looked at the European universities, which had created these departments, various disciplines of science, and that was adopted at Hopkins, and then Flexner pointed that out as the way to go forward. That is the structure that we've been with for, well over 100 and some years. And everybody seems to be saying this is a problem. Renee, you pointed out, I think something that we've been thinking about is, no, CAP is ready, but it's at the department level. So the department's not necessarily advancing the way we think it is. It's part of the cause of the silo formation. It's a barrier to cross-disciplinary work. So I would say that we need to keep pushing on changing the structure. It's not going to be in the form of a revolution, but it is something that I think CTSI can really push hard at.
And to that point, one of the major pieces we talked about in the report was that NIH itself, with its institutes and centers, categorical, is propagating this problem, and that one of the jobs of the CTSA program consortium is going to have to be to look backward at it and say, no more fighting, there's got to be a lot more coordination. And that's a hard job because we're both focusing out of NIH and back at NIH. Again, not worth the effort in a way because it's distracting, but on the other hand, practically, it's really important.
So, go ahead, Deborah.
Yeah, I just, in listening to everybody, have been sitting here wondering, well, maybe what we ought to do is take SOS. Maybe we ought to take all of RAP. Maybe we ought to get all of our BRAID partners to take all of their pilot funding money as well and do a similar thing to what Chuck just recommended. That is, let's have patient advocates and have some of the advocacy groups represented there and only fund, or not only, but primarily fund groups that are multidisciplinary in ways that we could easily define.
Yeah. Yeah, it's a really, really interesting idea. I'm having to sort of bite my lip because we've been working on some of the very things that you guys are talking about. And in fact, Keith, this is what you and I are meeting about later this week. Mike McCune has been advancing this, and we've got some ideas that we could pull this nicely together. But that's not what this panel's about. But I, as the moderator, I get the last question. This is a hard question, and one sentence is fine. One of my friends looked at the agenda for this this morning, and he's a good friend. I won't name him because I don't want to keep that quiet. But basically, he said, "What the heck are you doing?" He said, this open innovation idea, this, get ideas from a bunch of people, brainstorming, has never actually proven to work. And I pointed out to him, we know it doesn't really necessarily work, but we get some great ideas from it. We always have. And also, it's a great way to get people open to the notion of innovating, to bring their minds up to say, I'm not going to resist, I'm going to participate in it. And also, we do take their ideas and move them forward. But his point was the best models of innovation are where a group, usually a diverse group, focuses on a problem, a critical problem, and dives deep and doesn't leave the room until that problem's solved. And the other thing he said was it's not so much
them solving it fresh the first time, that generally 95% of the time the solution's already been come up with, it's just somewhere else. And it's a matter of finding that solution and applying it to you. Maybe it's in the auto industry, but it could work for you. So my question to you is, what questions then should we be diving deep in as a CTSA going into our renewal? And I know that's a hard question, so if you want to pass, that's fine. Gary, I'll give you a pass right off.
I was going to let you go first, and then agree.
Yeah.
So can I
Reg
jump
is
in?
ready.
Yeah. So I agree with your friend in a sense. So many of these panels, people are just running out bromides and platitudes, and you hear the same thing over and over again. So I think what you would really be nice to do, though, is think about how you can actually do experiments, right? Set it up so you'll try a few things, and what can you actually try it, see if it works. If it works, you incorporate it. So we do pilot studies that will make it work. And so you get away from just talking about things, because that's what we hear a lot, but actually try them and see what data you get out of it.
Good, and just to be clear, that is what we're doing today. So in the discussions that you guys have in your table, around your tables, we are funding pilot studies around the ideas that you all embrace to ask to go forward. But that's at a small scale. You're suggesting, but you're suggesting it at a bigger scale. I think that's a great point.
No, go ahead.
Well, I just ponder as I listen to the conversation whether one of the questions isn't who's missing from the conversation. So if we've got the typical suspects in the room right now, we very rarely challenge ourselves to ask, well, who's not here with a perspective? We've picked on patients and patient engagement groups, but I wonder if that couldn't be a thread that comes through each of the innovation ideas that you'll discuss this afternoon.
So I think I would ask two different questions, and maybe they could be put together. And one is, how do we improve the nation's health? And while that sounds like an insanely big problem, if we were locked in the room or locked at the table and couldn't leave till we solved that and had to take off our hats that we traditionally think from, how different would our thinking be? And the other part of that, or the other question I would think is, what am I most afraid of? Because I truly believe, and this may sound like, often people say it sounds like you drank some Kool-Aid, I think if we address what's deeply in us that we fear the most, that will bring us to great innovation and better collaboration.
So I have one comment, and then one of the great questions of life, right? So the comment is one of the ways that where you really understand what you're doing and what the value of each is to use, and I hate to sound sort of bureaucratic about this, but zero-based budgeting. I don't know if you guys do this or not. We tried that this year, and boy, that was interesting. Where you really have to show your value to the organization and to the community before each year before you can justify the scarce resources being applied to you. And then the other would be, actually, it's similar to yours, but maybe on a smaller scale, is what does success look like? What is success? So for each of the ideas that you're coming up with, what does it look like with success, and what impact does that have?
So I think the CTSAs and the CTSI here in particular occupy kind of a central position to try to do an experiment that has nice features that others in the panel have talked about, and that is that it's scalable in ways that you can start with a scale that will work. And that is to build this idea of a continuum, that we need to feel that each of us who are approaching our problems from our points of view, with our expertise, can do it better because we're here, because we're in this community. That community could be a subset of UCSF, it could be all of UCSF, it could be the CTSAs. Overall, it could be the UC grade, CTSA network, and so forth. So how do we do that? Well, the ideal would be if everybody kind of understood from ranging from curiosity-driven research all the way through the community out into the community of patients and citizens. That's a big call. So what if we could just gain a measure of appreciation, each of us, for the fact that the individual to our left and to our right, it may be doing things, thinking about problems in a slightly different way than we are. But because they're doing that, the ways that we think about those things can be better. And I think that would be an aspiration that we could reach, that we could scale experiments at that level and really have an impact.
Great, good. Well, I want to thank the panelists. This has been a fabulous discussion. I really